Thank you for having me here. I'm very excited to talk about ultrasonography, and I have no disclosures. So the RB, the forgotten ventricle, no longer. The RB is a very complex structure, and I'm going to try to convince you today that using bedside ultrasound or echocardiography really changes the management of your patient. Sometimes I go to the bedside, I have an idea of what I'm going to deal with, and after doing that ultrasound, I have a second opinion myself. Because ultrasound either corroborates what you were thinking already or sends you in a very different path. So I'm going to start with a case that I saw when I was a fellow in New Hampshire. And I think this case is going to illustrate the advantages or the importance of ultrasound and also the limitations in very complex cases. So this is a 62-year-old woman with a history of ovarian cancer, went to the OR, she had resection of her cancer, and she became profoundly hypotensive. So I was a fellow at that time, and the differential diagnosis was the patient in anaphylaxis, was the patient bleeding, what was going on with this patient. So the first thing I did is put a probe on the chest, like Matt said. That's what I did. And the picture is very different. You actually don't want to see this picture at all because this is an irreversible condition probably. What we're seeing is a longitudinal axis. So on the bottom of your screen, on the bottom, you are seeing the left ventricle, that it's completely obliterated. And then you're seeing on the top, the right ventricle. So this patient, it's on a death spiral, basically. If you see this echo on a patient in the ED or in the ICU, most of the times you don't have a stable patient, and you will go ahead and do systemic thrombolytics or some sort of thrombolytics to try to reverse this condition. You may not have the time. In this situation, that was contraindicated. The patient had surgery. So what we did is we actually took her for a pulmonary angiogram. And the pulmonary angiogram showed that the pressures were increased, but there was no obstruction. So again, most of the times it's going to be a pulmonary embolism, but not all of the time. Unfortunately, this patient died, and then we did an autopsy, and we did very special stains. And this patient had a very rare condition. She had pulmonary tumor thrombotic microangiopathy, and she died for the increased vasoconstriction causing the RV to fail, and there was nothing that we could do about it. Years later, I started my first job in Washington State, and I see this 35-year-old man. They called me from the emergency room. The patient was in respiratory failure. He had a representative X-ray that shows that, oh, there's some pneumonia there. It was a very busy night, so the patient comes to the ICU. By the time I'm seeing the patient, he was already having a difficult time. I had to intubate him. And then what happens next is he has cardiac arrest. And then 10 minutes later, he has another cardiac arrest. So what do? I need to find out why is he having cardiac arrest. I don't know. The quote unquote pneumonia wouldn't explain. So again, I bring the ultrasound probe trying to figure out exactly what's happening. Well, unfortunately, we had a very old sonocyte with a small screen, smaller than one of these laptops, and you have an obese patient with small windows. Well, I had to call the technician to come stat. He comes to the bedside with an echocardiogram, and I see this. So what I'm seeing is this is what we call a parasternal short axis. So imagine if you have your parasternal long axis that it's pointing, your pointer at 11 o'clock, then you rotate clockwise to around 2 o'clock, and then you have a short axis of your left ventricle and your right ventricle. And what you're seeing here is that the right ventricle, it's enlarged, and it's causing this D-shaped form. It's flattened the septum, and it's really bowing to the left, both in diastole and systole. So what do I do next? Again, this echocardiography is by no means your diagnostic test of pulmonary embolism, and I want to make sure that we all understand that. This is not your diagnostic test. But you have a patient who is very unstable, and now I have a very high pretest probability that this patient has pulmonary embolism, and I'm just trying to save his life. We gave him systemic TPA, and the patient stabilizes. Of course, the patient did very well, will come many months later to thank everyone in the ICU. What echocardiography and ultrasonography gives you is the ability to look at these elements. We all know that this is what the elements for mean arterial pressure, your cardiac output and your SVR. Well, when you look with the ultrasound, you can look at the afterload, the contractility, and the preload. And my talk is focused on the right ventricle, but it's true for the left ventricle too. So at different levels, I mean, there's what we call basic and advanced levels of echocardiography at the bedside. You can identify if the LV is working, if the RV is working, if there's biventricular failure, is there any other cause of shock? If you get more skills, you can actually calculate all the hemodynamic data, like Matt was saying. You can calculate the cardiac output, you can calculate the pulmonary systolic pressures, you can calculate the SVRs. And then you can also add other information from the lung, abdomen, and your extremities. 2 weeks ago, I had a patient with an intra-aortic balloon pump, and we were consulted. The patient, quote unquote, had cardiogenic shock. We go to the bedside. Of course, we grab the ultrasound probe, and the LV was hyperdynamic. So that's telling you that probably is not a cardiogenic shock. However, you don't have the full picture, because without knowing the cardiac output, you don't really know exactly what is the cardiac output. If the patient is hypovolemic, the LV can be hyperdynamic. So the cardiac output was 10 liters. We calculate the SVRs was 500. So this is certainly distributed shock. It's not cardiogenic shock. So the next step is trying to find out what was the problem. We knew that the X-ray was clean. We know that the UA was negative. We just slide the probe to the right upper quadrant, and we saw that the gallbladder was distended and the wall was very thick. So it gives you more information. It's not just looking at the heart. You can look at you can look at the abdomen and lungs to gather more information. So the right ventricle, why does it fail? Well, it fails when there's decreased preload, increased preload, when there's decreased contractility, and when there is increased afterload. The right ventricle is very susceptible to increasing pressures. Why? Because it's normally a low pressure system. So anytime that the pressure increases, it's going to suffer, it's going to dilate, and it's going to cause decreased contractility. In the ICU setting, the most common cause of right ventricular failure is increased RV afterload. There are many reasons. The problem with that is when you see that in the ICU patient who is mechanically ventilated with ARDS, well, sure, it can be pulmonary embolism, it can be the ARDS, it can be many things. What you're seeing is that the right ventricle is dilated and is not contracting very well. But as you see, it can be from the left-sided heart failure, or it can be related to the other side. What do we do when we have the ultrasound probe? I guess after we examine the patient very thoroughly, we look at the RV size, we look at the function, but we can also do some hemodynamics. So if we categorize those things that we talk about into preload, contractility, and afterload, I'm just telling you some of the things that we look at, because again, you saw the first image, the right ventricle is a very complex structure. It's very challenging, more challenging than the LV. So for preload, you can look at the IVC. Again, it really depends on where you're looking, and sometimes I think that's the confusion. In spontaneously breathing patient, the IVC tells you the CVP. So that's being validated, no questions. In the mechanically ventilated patient, what the IVC can tell you is more about the distensibility. So that will translate into if the patient is preload dependent or not. Would the patient respond to volume or not? In terms of contractility, so one important aspect of the contraction of the right ventricle is the longitudinal contraction. And one way to measure that is actually looking at what we call TAPSE. So that's with an M mode, you can see how much it goes up and down. And we can also look at the velocities with tissue Dopplers. And in the echo lab, they do other more sophisticated stuff. They can do fractional area of change. They can do longitudinal strain. So there's other things that you can do. What do we do at the bedside? It takes a couple of seconds, and I do all the time. You can check a TAPSE. You can check an S prime, and it can give you an idea of the longitudinal function of that RB. What do we do for afterload? How do we know that there's increased afterload in the RB? Well, you can calculate the pulmonary systolic pressure. Usually is your RBSP, and that's taken from a TR jet, and you basically calculate the pressure gradient, and then you add that to the right atrial pressure. I know it's some steps, but once you gain some of those skills, it takes really minutes. There's other things that you can look at, the RBOT, BTI. Matt talked about the BTI. Well, the same thing you're doing at the BTI for the left, you can do for the right side. You can calculate the cardiac output on the right side, but you can also look at the Doppler configuration, and sometimes it can actually tell you a lot. It can tell you when it peaks very fast, it peaks, and then there's a notch. It can tell you that there's increased pressures. And there are other things that you can look at. So again, just to illustrate how it impacts management, I'm going to give you another case that we saw a couple of months ago. This is a 65-year-old woman who was admitted with shortness of breath to the cardiology service. And he was admitted to the cardiology service with a diagnosis of NSTEMI. The patient had elevated troponins. They call us because the patient was in respiratory distress. She was hypoxemic. She was clear to auscultation. The X-ray was clear. Again, the point of care ultrasound shows that there was an A-line, A pattern. So there were no B lines. Well, it's not plain, but I think this still image gives you an idea. It's the same thing. You see, this is the partial short axis, so you're seeing the LB and the RB in short axis, and what you're seeing is that the RB, it's enlarged. I mean, the ratio between the RB and the LB should be like around 0.6. Here you see that it's really big, and it's D-shaped, and the video will show you that it was both in diastole and systole. I did some other calculations. We can get the pulmonary arterial systolic pressure. We get the TR jet. I know it's 45, so there's a pressure gradient, and I add that to the right atrial pressure, and her pulmonary pressures were around 55 to 60. So what is probably on the high side for something acute. Then we look at the longitudinal function. So that's basically the longitudinal function of the RV, and we discussed that we can measure with TAPSE. That's an M mode, but you can also measure with tissue Dopplers. Again, you put the marker there next to the tricuspid valve in the lateral wall, and it will tell you the excursion of that lateral wall. And what it's telling you is that it's severely depressed. It's 6 centimeters per second, which normally it's more than 9.5. So the patient had renal dysfunction, so we couldn't do a CT to diagnose her with a PE, but she had bilateral DVTs. So it completely changed the management of this patient. But you can see how these patients present differently. I mean, one patient, with acute respiratory failure and then cardiac arrest, and this patient was just presenting with hypoxemia. The patient was not in shock. So that also tells me that probably there's more chronicity in this situation. So I have been showing you all these images from how the RB and the LB and the ratios and the septum. So the septum is really important because usually normally the RB end diastolic pressure is usually less than the LB end diastolic pressure. So usually the the septum bows to the right, both during diastole and during systole. When the RB dilates and the pressure exceeds the LV and diastolic pressure, so that you are going to start seeing that the septum bows to the left in diastole. And when the pressure is also higher in systole, then you will also see that it was going to bow during systole. And I think one of the things that we have to remember is sometimes when we have these discussions, we forget to differentiate between the LV and RV. We'll say, okay, well, we have to give fluids because the RV is not contracting. And well, let's just look at this graph. So on the left side of your graph, you have afterload, and you see what happens to the LV and to the RV. So when the pressure goes up, the afterload goes up, the left ventricle stroke volume decreases slightly. But look at the right ventricle. When the pressure goes from 10 to 30, it just goes down abruptly. So the way they behave to increase afterload is completely different. And the reason is because, again, it's a low pressure system, and also because it's a very thin wall ventricle. On the left side, on the right side of your slide, you can see what happens when you increase the preload. Again, when the preload increases, your left ventricle stroke volume increases dramatically. When the right ventricle, that happens in the right ventricle, is more modest. So I think we're going to present the last case. I still have a couple of minutes. No. This is a patient who presents to the ED, had a witness cardiac arrest. In the ED, he looks stable. He looks fine. We take a look with the ultrasound right away. Oh, well, the image is not showing, but again, the first image is basically partial thoraxis, where it shows you that enlarged RB with D shape and septal bowing to the left. And this image, which, let me see if it plays. It doesn't play. So when we look at the patient, we knew that the patient had high pretest probability of having a pulmonary embolism. So we gave systemic TPA, and since the patient was stable, he underwent a CT. He got a CTPA protocol, would confirm the PE. What I was trying to point out in this slide, in this echo clip, is that it looks like the longitudinal function is preserved, but the radial function is affected. So there are limitations of these tools that we use. Sometimes there's discrepancy, and you look, and it looks like the longitudinal function is preserved, but the radial function is, it's severely impaired. What we did, there are other more sophisticated and more sensitive tools, and in our lab, the echo lab at St. Luke's, they did a limited echo after that, and we knew that actually the longitudinal function was decreased. And this is what we call a longitudinal strain, and they speckle different parts of the RB free wall, and they can look at all the, the deformation of those myocytes. And the value that they're giving you is -8, usually has to be more negative than -20. So it was severely impaired. Unfortunately, this patient, despite receiving systemic TPA and actually ended up getting catheter directed as a rescue, the patient didn't survive. What I want to bring is this table that shows you how these different signs, behave and how they perform. So the signs that we have are really not sensitive. The most sensitive that we have is what we call the RV end diastolic diameter, and it's only 80% sensitive. And what we know is that many of them are actually highly specific. Of course, if you see a thrombus in transit, it's pretty specific. McConnell sign is also thought to be specific. I've seen it in other RV infarctions, and we probably have seen it in other situations. But again, it's if you combine all these signs, all these different echocardiographic signs with the rest of your exam, then your pretest probability increases. Like I said, I mean, if you combine your A-line pattern of a lung that shows that there's no interstitial edema, and then you actually combine it with other signs, makes your pretest probability much higher. There's we kind of mentioned briefly that there's also the notching, the early notching of the RVO-TBTI that has been described for a long time, and there's a new study that has to be confirmed in larger studies, but also shows a very high sensitivity and specificity. And I'm just going to mention quickly. So here is that this is actually our patient, and this is the example from the book. And basically, the envelope, the Doppler profile, peaks here, and then there's notching. Instead of going all the way here, it just notches here. And it was very sensitive and specific for both submassive P and massive PE. And this is the explanation, is just flow deceleration. And so to summarize, how do we evaluate what can we do at the bedside to evaluate the RB? I think you can evaluate the anatomy, you can evaluate the size, the ratios that we talk about. You can also look at the diameter. It's not difficult to measure the diameter if you have an ultrasound that have those tools. Sometimes the wall thickness gives you the idea if this is chronic or not. Sometimes we have a population with pulmonary hypertension, and you look at the RB, and well, they have chronic volume overload, and you see that the RB wall is really thick. It's more than 5 millimeters. You can look at the function. Things that we can do at the bedside, we can look at the longitudinal function with this TAPSE and TDI. The lab can do other measurements. And again, it's really actually there's a lot of hemodynamics that you can calculate at the bedside once you get proficient in doing the basic ultrasounds. I think that more than important, I think it's an essential tool. I think we're going to get to the point that, you wouldn't be, in order to evaluate a patient in shock and respiratory failure, you actually have to use the ultrasound, because it really narrows your differential diagnosis and sometimes sends you in a very, very different path. We know that the RB anatomy is very complex, and it's certainly challenging. It's important to understand the limitations of many of these parameters. Sometimes you say, oh, it's a mechanical sign, it's P. Well, yeah, it's thought to be specific, but there are other things that can cause that. But actually, at least you know that there's something else that you need to do, that you don't stop there. You don't see mechanical sign, and you know that you need to do something else depending on, how comfortable you are, and you may have to, ask for a formal echo or not, or do the next diagnostic test. Well, with that, thank you.